Finding Hope, the Road to Recovery.
Hi, my name is Kris Lee. This is episode 2 of Finding Hope, the Road to Recovery. Today I'm here with Dr. Ken Bachrach, the Clinical Director of Tarzana Treatment Centers. Hi, how are you?
Fine, Kris. Good to be with you.
Okay, great. Nice to see you. Today we're talking about co-occurring disorders. Could you tell us a little bit about when and how did you end up working in the field of substance abuse and mental health?
Sure. Well, I went to graduate school to become a clinical psychologist, and when I finished that, I was kind of on the fence between whether I wanted to go more an academic research route, like teaching at a university, or doing more clinical practice. And so I ended up doing a postdoc, and after I did that postdoc, which is more research-based, I said, I really like research to some degree, but I don't want to do it full-time. I want a clinical job too. So I had a small part-time private practice, and then I saw this ad for this place, which was Tarzana Treatment Centers, and I interviewed and got hired as their clinical director back in 1987. And so when I was in graduate school, they didn't really cover that much about substance use disorders. So I have been learning over the past 35 years about treating both substance use and treating mental health problems.
Wow. Could you tell us a little more about co-occurring disorders?
Well, co-occurring disorders refers to both having a mental health disorder and a substance use or addictive disorder. And you may hear me use those terms, substance use or addiction, kind of interchangeably. In the past, they called co-occurring disorders dual diagnosis. So some people may be familiar with that term. Mm-hmm. But basically, it refers to treating both of those disorders. And that's really what that refers to.
I would love it if you talked a little bit for the viewer, the role of nature versus nurture.
Okay. But before I get to that, I did want to say a little bit more about co-occurring disorders, because it may not be clear what a substance use disorder is as well as what a mental health disorder is to people. So when you think of addiction, you think of abusing different substances. And so the most common ones are alcohol, and now everyone's familiar with what they call the opiate epidemic, which could be things such as pain pills, but it could also be things such as street drugs like heroin.
Or fentanyl.
And fentanyl is kind of one that's both, is probably the most abused drug right now and is causing the most deaths. When people hear about the opiate epidemic, much of it is due to the fentanyl use, that people are dying from that. But there's also other substances. Methamphetamine never went away. It was big in the 90s and early 2000s, but it's made a comeback, and a lot of people now are still dying and overdosing from methamphetamine. And then the last one are what are called benzodiazepines. These are the minor tranquilizers. These are things like Valium, Klonopin, Xanax, Ativan, those type of often sleep medications that people often take thinking it's going to help them, but then they get addicted to that. And it's very hard to get off it on their own, particularly if you're using a lot of it. So that's the whole class of various substance use problems. In the mental health field, there's a whole variety of various mental health problems, and they're in different categories. So the most common one people probably are familiar with are depressive disorders. Mm-hmm. These is where you get very sad and depressed, and often you can even get suicidal. There are also anxiety disorders. The most common people think of are things like panic disorder, social anxiety, generalized anxiety. That's very common too. There are things that are called obsessive compulsive disorders, where you either are thinking about things a lot or feel like you have to do certain patterns or rituals all over again. A very common one too is trauma-related or stress disorders. We think often of post-traumatic stress disorder. That can be everything from someone who has been in war or combat and experiencing very stressful things, to basically being abused as a child, being victimized, everything sexually or emotionally. And then there are other disorders that are called like mood disorders. The most common one is bipolar disorder. That's used to be called manic depressive disorder. And that's where you have mood fluctuations. And some people have big mood fluctuations, some have more minor mood fluctuations, but they seem not to go away. And that actually is the disorder with the highest rate of co-occurring disorders, meaning people with bipolar disorder are most likely to have a substance use disorder more than any other mental health disorder.
Wow, I didn't know that. Wow.
Yeah, so this could be up to 60% of people with bipolar may develop an addictive disorder, while with depressive disorders, it's only about 25%. And then the last category are the ones when you think of severe mental illness usually. Those are often the psychotic disorders. Those are things such as schizophrenia, schizoaffective disorder, where you have both the kind of the psychotic part and the mood part combined. And when those disorders are most troubling, because that's where you start maybe hearing voices, seeing things, they're called hallucinations, having delusions, being paranoid. Those are the kinds of things that you can have. And some of these things that I've described on the mental health side are things that you can also develop from using drugs. So when we're dealing with co-occurring disorders, we have to look at everything and try to figure out what's going on. Is it a mental disorder? Is it a substance use disorder? Can it be both? I remember I had a mentor who used to say, just remember, a dog can have fleas and ticks, meaning you can have both of these things. So you've got to look, and when you do your assessments, you've got to look for both of them.
Okay.
Now, you asked me then about nature versus nurture.
Mm-hmm.
Well, that refers to how much of it is biological or in genetics, meaning how much did you inherit, and how much is a result of the environment in terms of how you're living your life or the environment you're living your life. So, for example, we know that people with addictive disorders have very high rates of trauma. That could be everything from growing up in a home that's very unstable, where there was a parent with mental illness or substance abuse, where they were victimized. It could even mean where there was instability, everything from homelessness, a parent went to jail, a parent died, the parents divorced. All of those things can lead to instability growing up. So those are things that can happen. The other part is, do your family members, particularly your parents, do they have a history of either mental illness or substance use too?
Which is a predisposition to addiction and mental health issues, correct?
Exactly. So very often people want to make it one or the other. But like most things, it's never that simple. And I'll give you an example. We know that people who grow up in families where at least one parent had an alcohol use disorder, they are 4 to 5 times as likely to develop an alcohol or substance use problem as people who grew up in families where there was no history of addiction. So you might say, oh, that's good to know. But when you think about it, you're mixing the genetics, right, with the home environment. So how do you tease that apart? Well, there were some clever researchers in Scandinavia who looked at kids where one parent had an alcohol use disorder, but they were adopted out at birth, and they were placed in families that had no history of addiction. Those kids, when they grew up, still had a 2.5 times greater likelihood of developing an addictive disorder.
Wow.
So if you look at it, 2.5 times seems to be clearly mainly genetics, while 4 to 5 times is a combination of the two. So what that shows you is that both can play a role. So you really shouldn't be pointing your finger one way or the other, but also realize even if you don't have a history of substance use in your family, you still can develop a substance use problem if you have certain predisposing factors that put you at greater risk. It's kind of like other diseases when you think about it. Just because you have a family history of cancer, it puts you at greater risk, or a family history of diabetes may put you at greater risk, but that doesn't mean you will develop those disorders.
Right.
So that's the thing we need to keep in mind. And we know that trauma, instability, and all of those things put you more predisposed to developing it as well.
Okay. So when I used to be a substance abuse counselor at Tarzana Treatment Centers, in my initial session with a new client, when I would do an assessment for strengths and weaknesses, one of my main questions was that, do you have a mental health disorder? Have you ever been diagnosed with a mental health disorder? Or are you experiencing mental health symptoms? Almost every single time, the answer was yes. So my question is it possible, and this could be a sweeping generalization, but is it possible for someone who's diagnosed with a substance abuse disorder to not have a mental health diagnosis?
Yes, it is. We know that actually people with substance use disorders have higher rates of mental health disorders than people with mental health disorders have addictive disorders. But it's not 100%. You see what I'm saying? It's not just because you have a substance use disorder doesn't mean you have a mental health disorder. And part of it is you have to look at, while most people with addictive disorders have a lot of maybe mental health symptoms at some point, that doesn't mean they have a chronic mental illness or something that's going to stick with them forever type of thing. Now, almost everybody deals with some types of mental health symptoms.
Absolutely.
It's part of life. You have stressors, you have ups and downs, but that doesn't mean you have a mental health disorder. It's not something that is constantly impacting you in your day-to-day living. And it's something that often can go away over time given changes in circumstances. Some people, though, will have these mental health disorders. And so what it requires is that you understand how to evaluate both the substance use disorder. For example, you as a substance use counselor, you know how to assess a substance use disorder. You know how to look at the various dimensions that you should be assessing, look at how much they've been using, if they meet certain criteria for use, if it's mild, moderate, or severe. Well, you need to do the same thing to assess a mental health disorder. And so just like we know that everybody who went to war doesn't develop PTSD, even though they may have been exposed to the same horrific experiences in war. So why is it that maybe a quarter of the people who are in combat develop PTSD and the others don't? It may have to do somewhat with one's resilience. You know, we often look at how can some people are more resilient than others. And it may also have to do with the fact that they have less of a predisposition to developing based on the genetics as well.
Wow, you're clearing up a lot of misconceptions. As you know, there's a lot of stigma on mental health and substance abuse and people who are struggling with addiction. So thank you for doing that. But that brings me to my next question. How do you go about, if you could be more specific, about assessing for someone who has a co-occurring disorder? Can you talk a little more about that?
Sure. So there's a couple of ways you go about doing this. You kind of get the person's life story, meaning you start in childhood and you ask, when did these symptoms start to develop, being the mental health symptoms? If we know, for example, the person started developing depression, anxiety, they were exposed to trauma and they had a lot of stressors and they were having trouble coping, and then they started using substances, maybe as a way to cope and things like that, we're pretty clear then that they probably first had the mental health disorder and then they developed the substance use disorder. Now, again, just like everybody who uses substances doesn't develop a substance use disorder too. We see that with a lot of people. We know that in adolescence, there's a lot of substance use, the most between the ages of like 15 and 25, or even up to 21 in particular. That's when the highest rates of substance use happen. But not everybody becomes addicted. One great example, look at what happened in the 1960s and 70s, where there was this huge amount of substance use in this whole cohort of what are now baby boomers. There were a lot of people who got addicted, but there were a lot who experimented but didn't get addicted.
What were they addicted to?
Well, the same drugs we see today. It was alcohol, it was heroin, there was some speed at that time. There was methamphetamine, but there was that. And then they were using also more kind of other drugs, more psychedelic drugs, or more major tranquilizers and things like that, barbiturates and things like that, which we don't really see anymore. But so a lot of people use substances and then they didn't develop it, but some did. That wasn't really talked about that much then. Addiction is talked about a lot more today than it was 50 years ago.
Yeah.
The other thing is, so if you're looking at someone and taking their history and you see their mental health problems develop and then their substance use, again, not everyone will get addicted, but they may develop then an addictive disorder. The other thing that can happen is that they start using substances. And then there are certain mental disorders that don't develop early in childhood. Some may develop in later adolescence and early adulthood. So therefore, if the person's using substances and then those symptoms develop later, it's hard to know what came first or if one was triggering the other. What you have to do is you have to do a good assessment of both. And if someone is using both substances and you think has a mental health disorder, the first thing you have to do is you need to stop the substance use, because you need to see, how does this person function when they're not using drugs? Because one of the concerns you have when someone is using substances and may have a mental health disorder is that you don't know if these symptoms are what we call substance-induced. So for example, very often when people stop using certain substances, they get very depressed. They may get paranoid. They may, while they're using substances or right when they stop, they might get, start having hallucinations, hearing
Audio
voices.
And visual hallucinations.
Exactly.
Yes, correct.
So how do you tease it apart? The only way you can do that is you have to get the person off drugs. Now, one of the nice things at Tarzana Treatment Centers is that we offer the full continuum of care. So if someone is using substances and they come in with mental health symptoms, we can put them on our inpatient unit, which is actually licensed as a psychiatric hospital, but we also use it for detoxification.
And stabilization, correct?
Right. So we can get them off their substances, and then we can see, are those symptoms still there? And sometimes it may take a week or two to really fully evaluate it. But we have the staff to do that. We have psychiatrists, psychologists, social workers, as well as drug and alcohol counselors. We have nurses. We have a full continuum of different specialists who are able to do these things and help with that differential diagnosis. Once someone is off substances and then, let's say, moves to the next level of care, which could be residential treatment or it could be outpatient treatment, then we can better evaluate how much of it is mental health and substance use. The thing that people also don't recognize is that when someone stops using substances and it's not in their bloodstream or in their urine anymore, that doesn't mean they're fine, because recovery can take a long period of time. People, particularly during the first weeks and months, may still be in a fog. They may have trouble remembering things.
And it can take up to several years.
Exactly. They've done studies, for example, that they looked at brains of methamphetamine users. And what they found is that they took brains of people right when they stopped using. It took 2 years for their old brain for their brain to look like their old brain, or what we call a control brain, meaning a normal person's brain. So generally, sometimes it can take 1 to 2 years. And that explains a lot, because people who are family members, for example, expecting someone to kind of return to normal, so to speak, right away, may be disappointed, because that person is still experiencing a lot of cravings, has a lot of uncomfortable feelings, starting to experiencing emotions without the use of substances, learning how to cope with life, learning how to to live life without drugs, basically.
Starting all over again.
Exactly.
Yeah.
It could be everything from learning how to structure your day, learning how to talk to people.
Absolutely.
And one thing that, is never talked about is having intimate relationships when you're not using drugs, because so often, and with many drugs, that's a big part of the drug use, particularly like stimulants like methamphetamine. Not so much with opiates and stuff like that, but particularly with stimulants like methamphetamine, cocaine, and alcohol. Those are the ones that are often associated with a lot of sexual activity too.
Sure, and codependency is a major problem in addiction. So how do you determine the appropriate level of care of someone who has a co-occurring disorder?
So again, it comes down to doing a good assessment. You put the person at the least restrictive level of care. So if someone is using substances and they can't stop on their own, very often they may need to go inpatient for detoxification. It's often referred to as withdrawal management now, but that means under medical supervision, they are slowly withdrawn from their drugs, and then they can move on to either residential or outpatient treatment. Similarly, if someone has a psychiatric condition where they are at risk of danger to themselves or danger to others, they may have to go to an inpatient facility until they are safe enough and in enough emotional control where they can step down to the next level of care. For residential treatment, they need to be able to do their basic daily functions, so to speak. They need to be able to get up, go to groups, go to meals, make their bed, talk to people, get along. They need to have, those kind of basic skills. And sometimes when people first come into treatment, they are not quite there yet.
Yeah, they don't even know how to make their bed sometimes.
Right. Or they may be so tired or fatigued and things. And one of the things we've learned too in residential treatment is that particularly with certain substances like stimulants and methamphetamine, the effect of fatigue lasts much longer. So it's like day one, they can go to groups and things. They may be exhausted for a week or two, while someone else on another substance or alcohol or drugs within a few days are feeling pretty good, meaning that they can go to groups, they can function fairly well. So one of the things we do is we look at their level of functionality. We assess how they're doing from both a substance use and a psychiatric point of view, and figure out if they need maybe residential or if they can go into outpatient treatment. And for outpatient treatment, they need to be able to have the resources so that they don't use substances, for example, meaning what they need to do is they need to be able to have some structure in their day. They need to have a place where they can go to live. How they need to have housing, which may sound very simple to some people. They need to live with people who don't use substances.
Oh, aftercare is extremely important to someone's recovery.
Right.
Absolutely.
And psychiatrically, what they need is they need to have counseling. They need to see a psychiatric provider. They maybe need to have their medications adjusted so that they can, function well enough to be in an outpatient treatment program.
Okay. Thank you, Dr. Bachrach. Now we're going to take a quick break. Don't go away.
Welcome back, everyone. I have Kris Lee, who is Operations Supervisor of the Residential Treatment Program at Tarzana Treatment Centers. And before you heard from me talking a little bit about co-occurring disorders. But now what we're going to do is really make it personal. We have someone who is willing to share her life story with us, so you get a better sense of what co-occurring disorders is, as well as the fact how someone even with co-occurring disorders can become very successful and learn how to deal with both their addiction and their mental health issues. So Kris, thank you first of all for being willing to share your story with us.
Thank you so much.
So let's start at the beginning. We talked a little bit about how we try to understand co-occurring disorders. So let's start even before you were born, so to speak. Do you have any family history of addiction or mental illness in your family?
Well, this is a tough question for me. My mother was not very open about discussing private matters because we come from a very Christian, conservative family, and we are Korean, very Korean, and it's not really in our culture to talk about these things. But what I do know about my family history, especially regarding my birth father, is that while they were going through their separation, he did attempt to commit suicide.
Oh.
Yeah. Now, growing up, my mother being single, raising me all on her own, which I imagine would be so tough to do. Most of her 20s, she was heavily drinking almost every day. Now, she will never identify as an alcoholic. I'll tell you that right now. She will deny it till this very day. But I do believe that she had a drinking problem growing up. Yes.
So you've already mentioned that obviously if your father attempted suicide, there was probably a history of depression.
Absolutely.
In your family. And whether it was in your grandparents, you may not have known, but at least with your mother, you knew she developed a problem with alcohol.
Yeah.
Even if she kept it hidden, which was, very common at that time.
Sure.
So you already had those things going against you. You also mentioned that your parents separated and divorced.
Mm-hmm.
So that's another kind of traumatic
event.
thing.
Absolutely.
So that's already, as a young child, you're experiencing that. Did you have any other traumatic events in your life, and how did that impact you?
Wow, you're hitting me with all the tough questions immediately. So yes, the separation of my mother and father was traumatic. A year after that, I think I was only 4 or 5 years old, I witnessed my first death. I visualize and recall a whole family gathering in our home in South Korea. And I had observed my aunt, my grandma's oldest daughter, say, "Oh, I have a headache." And she collapsed, died of a brain aneurysm, and I saw my first dead body at that time. Now,
that really had an impact on you, it sounds.
Absolutely. And, as a child, you don't comprehend what's actually going on. What you do is you observe everyone's reaction and stress levels and what they're going through at the time. That's what you're feeling, and that's what you remember. That doesn't come back to really get you until later on when you become an adult and you go, that's what that was. The second thing was, by the time I was 6, my mother, after experiencing the separation from my father, decided, I'd like to start a whole new life in America. So she did. She moved without me to get acclimated in America. So I lived without my mother. So here we are. I lost my father and now my mother, even if it was temporary. And I'm living with my grandparents. So I did that for a year. And then I was moved to the United States. Now, I gotta tell you, I don't know if you've ever experienced anything like this, but as a child, when you have to relearn how to behave, speak, eat, I was using chopsticks, Ken. I had to experience, for the first time ever, cultural barriers and even racism at such an early age. That was really challenging at 6 or 7. And then the last thing, when anyone talks about trauma, the first thing that I remember is during my addiction, I was sexually assaulted by the same person twice.
Oh my God, so sorry.
And that was hard. That was definitely my rock bottom.
Boy, I appreciate you being willing to share that, but I know that's very hard to talk about. You mentioned a number of things: moving to a new country, being separated from your mom as well for a year, being thrown into a new culture,
Yeah.
learning how to speak a new language, learning new customs, and I suspect kids are not the kindest people. I'm sure you were bullied and teased and all of that kind of stuff.
Absolutely.
Which again, is also, really impacts you. When did you first realize that you had kind of some mental health issues? Do you think it was all the result of all of these events?
Sure.
Or you mentioned your father was depressed. Did you experience any depression growing up? Or was it more secondary to all of the trauma and new experiences that you had to go through, as well as obviously the assault that you experienced sexually?
Absolutely. All of those things contributed to my substance abuse. Absolutely. Regarding the mental health symptoms, I can't recall the onset of my first mental health, but I believe anxiety at the very least was always kind of part of my story at a very early age, especially physical anxiety. I felt it all the time. I think the onset of really severe depression didn't come until I was 18 years old. And that's when, coincidentally, when my heavy drinking and using also occurred. I learned how to self-medicate.
Well, you mentioned about anxiety coming on. That makes a lot of sense given what your story that you're telling, because given everything you've been through, you have to become vigilant.
Yeah.
And when you are vigilant, you are on guard all the time, right? You have to protect yourself. You have to see what's going on in the environment, because it is not a kind environment. And a lot of this stuff, we know now that there are parts of the brain that basically are hyper aroused and they can't settle down easily. And that contributes for many people to this kind of constant anxiety, you know what I mean, that they're feeling.
And my brain wasn't even developed yet. I don't have coping skills at the age of 7.
No, this is something very primitive in certain parts of the brain where most people learn when the danger's gone, it settles down. It keeps up there. It's kind of like related to cortisol levels, where they keep on up there and they keep the brain kind of revved up and vigilant. So you had some anxiety. You mentioned depression. So your substance use. So you had a tough childhood. Terrible things happened to you. When did your substance use start? You mentioned college. Was there any before that time?
Sure. I was smoking marijuana. I do believe it's a gateway drug, because it was for me. Not that I recall, pretty heavily, since I was 13 or 14.
And what did it do for you? Was it just to experience like getting high, or was it to deal also with kind of mental health symptoms like anxiety, or to calm you down, or things or cope?
So in the AA program, we call this self-bondage, right? So it allowed me to escape and repress everything that I knew, that I was feeling. Okay. It was an escape. I was running.
So that's an important point to make, because it sounds like you were experiencing these mental health symptoms, and then the substance, marijuana at least to start, became a way to cope or manage those symptoms.
Sure.
And it became an escape for you too, because when you're loaded like that, you're not really feeling those symptoms intensely until obviously you stop using, and then usually those symptoms come back.
Right, they sure do, yeah.
So it's not a permanent fix, it's a temporary escape. And that's one of the things with co-occurring disorders, is that that's where kind of the struggle comes in, because you like the feeling of using because it gets you away from those uncomfortable feelings, but you're never really dealing with it. And then you start developing your own addiction too. And it sounded like it got much worse when you went to college.
Well, that's the ultimate fallacy, right? Thinking that we can run away from our problems, and we just can't. You know, I learned that the hard way, that's for sure.
So in college, you said you started drinking heavily. Can you tell us, did something happen or what occurred? Because very often there's a lot of drinking in college, so maybe you can share a little bit about that.
Okay, well, what I didn't mention, at a very early age, I also knew that I was attracted to women. Now, remember, I grew up in a very Christian, conservative Korean family, and I was conditioned to believe every day that I was living in sin. So I had kept that a secret almost my entire life. Having that burden and keeping that part of you a secret, you're living in shame. You're not only living in shame, but you're living in shame almost every single day. And as you know, there's a lot of research on children who grow up in environments of shame.
Right.
Right? Mental health, substance abuse. You know, I'm the poster child for, you know, shame-induced mental health and substance abuse symptoms. You know, it wasn't...
So you were really having to live a lie in terms of who you were, and that was very stressful because you didn't feel you could obviously come out to your family because of your upbringing, and it maybe was even hard for you to even come out to other people too. So that kept in, as along with all these other things you had been through. So we see a culmination of number of different things,
Sure, progressive.
building and building and building. And then you said in college you started drinking heavily.
Sure, yes. So, you know, when you take away someone's capacity to be authentic, it starts eating away at you. So by the time I got to college, it just all of a sudden hit me. I believe, as I recall, that was the first time I attempted to commit suicide. I was on a 48-hour psych hold by the time I was 19.
Were you drinking at the time you attempted to?
Oh,
commit?
absolutely.
Well, I think that's important for our listeners to know that very often when people are using substances, that's when they will do things that maybe when they're not using, they may have second thoughts about, because you lose that impulse control.
Yeah.
And so I just think it's important to point that out, that you were drinking at the time that this occurred. And again, that when we talk about co-occurring disorders, that's what happens. They get mixed together. You're dealing with the depression, and you're dealing with the alcohol use and the addiction to alcohol, and you do things that normally you would say, why the heck am I doing this, if you weren't drinking?
And here's the thing, is that we often forget that when we repress or suppress or self-medicate, you're not just suppressing the bad, you suppress your capacity to be good and happy.
I think that's a great point that you're mentioning there, that you are looking at the glass always as half empty rather than as half full.
Oh, you have to, yeah.
Yeah. So obviously you made it through that period. What happened then after you got out of the hospital? Did your life improve? I mean, did you start? When did you start getting treatment, basically, for your mental health or for your addiction, or did it continue after college?
Oh, it definitely continued after. It was progressive.
Okay.
So I left college. I moved to Los Angeles. It was gradual, but it was progressive. It kind of just creeped up on me over time, and it was like a snowball effect. I was able to function. I had a decent, semi-okay acting career, and I was making money, and I had moments of happiness, and I had come out to most of my friends, maybe not my family, but I had come out. But then I was introduced to pain medication.
So first it was alcohol, you're saying, and then you got introduced to pain medication.
Yeah. When I was introduced to opioids, Vicodin, Oxycontin, that was the start of my decline. And
Did it do something that alcohol didn't do?
absolutely.
What was so attractive to you about those substances that alcohol versus alcohol?
It was much stronger, first of all. I can take a couple of pills versus having, endless amount of drinks to get to, where I need to be to escape. Once I realized I couldn't afford to pay for the pain meds, the $400 to $500 a day, by the way.
Wow.
Someone had come to me and said, "Wow, that's an expensive habit. Why don't you just try black tar heroin?" I said, "What's that?" And I remember this like yesterday. They said, "It's heroin. You've never heard of heroin?" I said, "That's for drug addicts," which is hilarious because I was definitely in my addiction and I was a drug addict.
And that's an important
yeah.
point, because people make this differentiation between taking prescription pain pills
Yeah.
versus taking heroin, when in actuality they're basically the same thing.
Right.
They're just a different form of it. Go on.
Thank you for clarifying that. That's very true. And next thing I knew, I was shooting up heroin every single day. I was committing crimes just so that I could provide for myself, eat, avoid withdrawals, and get my next fix. I had pushed away everyone that ever cared about me, family, friends. I was hanging out with and associating with gang members and other drug addicts.
So your life dramatically changed from being able to work and have structure, even though you were functioning and using, to where it sounds like your focus was just 100% on your addiction at that time,
Yeah.
in terms of either obtaining, using, or recovering from the effects of the drugs, and figuring out how you're going to get your next fix.
My goal every morning was in the front of my brain, the prefrontal cortex, and it was, most people wake up every morning and what do? You have a cup of coffee, right? You go have breakfast. That was not a priority when I got up in the morning. I experienced withdrawals every single morning. So my priority was to get high.
What most people don't understand is when you are in the throes of addiction, your brain gets hijacked by the drugs.
Absolutely.
It is like you're driving a car without brakes, but only a gas pedal, meaning that the ability to say, is this the right thing to do? Should I really do this? Should I be, it goes out the window.
Yeah.
People don't understand that dopamine, which is one of the major neurotransmitters in the brain that give us pleasure, when you're taking drugs, you get such a shot of that compared to other things in life that you are driven. And it's almost like that primitive brain to survive gets kind of kicked into high gear. And so I think that's important for people to understand, because they may not say, why did someone do that when they were loaded or when they were using substances? Why couldn't they just stop? Well, they can't, because their brain has been hijacked. Later on, when you're off drugs, you could say, why did I do that? And you may be ashamed of it, but at the moment, there was no question, right? You just had to do that.
Yeah.
There was no other alternative.
And I love how you clarified earlier that it doesn't matter if you're taking pain medication or if you're shooting up heroin in the back of an alley. An addict is an addict, and no one is exempt from the consequences of addiction. No one. I don't care how smart you are. Everyone experiences it.
So tell us now, you've told us when you were at the depths of your addiction. Tell us about your recovery. Did you just go into treatment and every day things were fine and you just said, boy, I'm glad I'm over that?
Yeah,
Tell us about your road to recovery.
Okay, great. So I want to first off say how grateful I am to Tarzana Treatment Centers. It took me a couple of tries. I'll be honest, the first time I relapsed, I even snuck out the back gate and brought alcohol back, and I was administratively discharged. But I'm so grateful to the program director, Dr. Stan Galperson. He gave me a second chance. And from there, I stayed roughly a year in the program. I received stabilization in the inpatient unit. I received psychiatry. I received the right and appropriate medications, therapy, and I stayed in the residential program for roughly a year. Well,
I'm glad you said that it wasn't kind of just smooth sailing, you just kind of came in once. Because we have a saying in the field of addiction, relapse is the expectation, not the exception, meaning that addiction is a chronic disease. And it's kind of funny, people don't think of someone who's depressed saying, once you're feeling better, you're never going to get depressed again, or once you have no other field has that expectation that once you're doing better, you're never going to feel bad again. And given that addiction is really, by and large, a brain disease, it takes over the brain, and we have to do things to kind of reprogram our brain and learn how to live without substances. It often does take multiple tries, and I think that's important for our audience to hear, that even if you don't succeed the first time, you can succeed if you go back again and again, and hopefully then can get some stability in your life. We know that now, that you were in treatment for a year greatly increased your chances, because one of the things we know that the effectiveness of treatment is partially the result of the dose of treatment. Meaning if you get it long enough, it's like any habit change. You can be on a diet, right? You can do it for a month, maybe even 2. God forbid you can do it 3 months, but most people will gain the weight back, right?
Yeah.
And
recovery is not a diet,
no,
Dr. Bachrach.
It's not a diet, but I think
it's a life change.
But I think that people can relate to that. Just like if you want to lose and maintain weight loss, it has to be a life change. If you want to develop a regular exercise program, it has to be a life change. Sure. And it's even harder with addiction because it's not just saying I need to do it, it's realizing that you're fighting things that are going on in the brain for a long time.
And I loved how you mentioned we don't have to stigmatize relapse. There's a saying that relapse sometimes is part of recovery.
Right.
And
I think that's the thing that we tell our staff is to, when someone relapses, welcome them back, because very often their friends and family will just feel angry and make them feel ashamed, so we say, thank you for coming back. I know it was hard, because nobody wants to relapse. Nobody wants to be addicted either. These things happen. Looking back, nobody sets out to say, when I grow up, I want to be a drug addict. So when people are struggling, we need to say, we recognize you're struggling, come back. It may take multiple episodes, but we're not going to give up. Just to give you an example, we don't say to a diabetic when they go to the emergency room, this is the 3rd time this year you've come to the ER. Aren't you ashamed of yourself? No, we just treat them because their blood sugar got to a point where they needed help or whatever. We just treat them, and we need to have the same attitude when we treat people with addiction. We're slowly getting there, but we still have a long way to go. So why don't you tell us a little bit more about from that point where you left to your success today, because I think it's important for people to hear not only about the struggles of addiction, but the joys of recovery and what you've made of your life to this point since that time.
So that same director, Dr. Stan Galperson, shortly after I graduated treatment, I received my first job in recovery as his assistant. And shortly after that, I went back to school to become a drug and alcohol counselor. And I worked at Tarzana Treatment Centers as a drug and alcohol counselor for several years. And then I recently got promoted as the operations supervisor of the residential program, which is my dream job.
Well, I'm so glad to hear that. I know you're choked up a little bit.
Stop making me cry, Dr. Bachrach.
Okay. I really appreciate you sharing your story. I think you are an inspiration, and I think it will be inspirational to other people, either because they are experiencing similar things, or they have family members, children, brothers, sisters, spouses, aunts, uncles, who are going through these kinds of things. And, you know, the good thing about Tarzana Treatment Centers is we help everybody, people with money as well as people who are down on their luck. And so we offer the full continuum of care, and we also have services that can treat both the addiction and the mental health. And it seems like that was something that you got when you went through Tarzana Treatment Center, and that is something that people with co-occurring disorders really need.
Right.
They need integrated care that treats both of them at the same time. Unfortunately, that's not what you find everywhere. Some places specialize in one or the other, but don't provide both of those things. So, you know, it is something that is needed. And, you know, thank you once again for sharing your story.
Thank you so much.
Thank you all for joining us.
Finding Hope, the Road to Recovery. Brought to you by Tarzana Treatment Centers. You can visit our website at www.tarzanatc.org or call 1-800-996-1051.